Good evening, everyone. I'm Heather. I'm going to be your host for the evening. So very, very welcome to you. I'm going to do a little bit more later. But the first person I'd like to introduce to you tonight is Murray Sigler. Murray is our CEO and president at the Calgary Health Foundation.
Thank you so much, Heather, and thank you, everyone, for being here tonight. It's a very important occasion, and it's my honor to be the president and CEO of the Calgary Health Foundation and get to meet so many people that are interested in the work that we do. Now, but before we get started, I'd like to acknowledge that we gather on the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary is also home to the Métis Nation of Alberta, Region 3. I want to note that our hospitals and Care West sites are on lands near where the Bow River meets the Elbow River, and that the traditional Blackfoot name of this place is Moginsis, which we now call the city of Calgary. I'd now like to introduce a number of our board members, volunteer board members who are with us here tonight. I'd like to ask each of them just to stand, and as I call their name, I'll start with our interim board chair, Sarah Kennedy, who's at the back over there. Sarah, thank you. I've got, I think, Leslie Hutchison, our vice chair, is in the room. Leslie, well, she must be en route. We've got Kathy Hanachuk, who's chair of our governance committee. Kathy, are you? There she is. And we've got Ida Libben, who Ida is a member of our finance committee and a major donor as well. We really appreciate, Ida, all you do and how we can work together as partnerships with Libben Foundation too. And of course, Dr. Mark Anselmo from Alberta Health Services. He's just a major supporter. We're pleased to work with Mark. So thank you all for there. And on behalf of our entire team, you see, you've got a chance, I hope, to meet many of my colleagues, Paul and others that are here tonight. We look forward, we appreciate the chance to get to know you. So, and thank you for coming to this, our Spring TalkHealth event. This event is to share information that can help each of us take ownership of our health by understanding healthy practices. It would not be possible without our donors, who ensure that healthcare remains a priority for our community. There are a lot of health challenges that are facing our city and Calgary Health Foundation. One that is a priority for our community and donors is women's health. Women's health is underfunded, under-researched, and not talked about enough. Today, we're going to open up the dialogue around this topic and are excited about what our guest speakers have to share. Calgary Health Foundation is in a unique position to work alongside Mark and all his colleagues at AHS to ensure that Calgary is home to the best care for everyone. In addition to women's health, some of the areas of care we are prioritizing include seniors' health, cardiac care, mental health, surgical innovation, and Indigenous health. We believe we can make a significant difference in these areas of care. In 27 years, our donors have contributed $575 million to healthcare, demonstrating the important role health plays in our lives and how important community support plays in making a difference. So we're very proud of the work that we've done, not just recently, but over the long term. We wouldn't be able to do that work without our donors. They make an incredible difference to many people, whether they are a monthly donor, an annual donor, or have made a commitment to one of our priority projects. So again, on behalf of all our team, our board, all my colleagues who I have the pleasure of working with, thank you again for joining us today to engage in a meaningful conversation about women's health. I'd now like to ask my colleague, Heather Innes, Director of Community Engagement and Donor Relations, to come back up here to introduce our program and speakers. Thank you.
Thanks, Murray. Thank you for your leadership, your passion, your commitment to engaging community members and donors in transformational healthcare. Good evening, everyone. It's awesome to see so many people joining us tonight. I hope you enjoyed the appetizers and that you're ready for an engaging evening. I'd like to thank the Carriage House team for all their support, Pink Sands for helping with the AV and our live streaming tonight. We have people online joining us as well. And the fantastic Calgary Health Foundation staff who've helped to make this evening possible. I am so proud to work with all of you every day. Tonight is about empowering you. There are challenges in healthcare, as Murray mentioned, but with your support, challenges are opportunities. It's wonderful to have you all in the room. As the slides say, we can all, women and men, achieve great things when we work together. And seeing men in the room gives me so much hope. It takes courage to be in a room full of women. But we don't bite. Well, at least not very hard. I'm super excited to learn from Dr. Brennan and Dr. Sandhu. Of course, as a woman, a mom, a sister, a niece, an aunt, the topic interests me. I'm also a member of the 1 in 5 women who have struggled with mental health throughout my life after experiencing significant childhood trauma. And I suffer from migraines, which are more common in women than men and affect over 30% of women between the ages of 25 and 55. My symptoms include neurological impacts that may be linked to an increased risk of cardiovascular disease and stroke. I have vision loss, I have numbness in my right side, and slurred speech. Research is ongoing to understand that link. So here we are, always wanting to learn more. However, tonight's not about me. Oh, maybe a little bit. Though, as Maya Angelou says, I'm interested in women's health because I'm a woman. I'd be a darn fool not to be on my own side. The way this evening will work is there's a pen and folder in front of you, which I hope you've already opened and had a look at. That's yours to take home. Inside the folder is the shared presentations from Dr. Brennan and Dr. Sandhu. So lots of opportunity to take notes, write as many notes as you like. We'll be sharing the presentations after as well, and we'll also share a live recording of the evening. I'll introduce our first speaker, Dr. Brennan, and then I'll hand the floor over. Dr. Brennan's presentation will be followed by a Q&A. So we'll have people around the room with microphones. Just put up your hand, and they'll come to you, just like high school. You can also write the questions on the index cards in front of you. Leave them on the tables, and if you have an email address, leave that as well, and we'll try to make sure that all your questions get answered if we can't answer them all in the Q&A. For most of you, we do have email, but if not, that'll help us share answers back with you. And then I'll return and I'll introduce Dr. Sandhu, who will present, and then we'll do a Q&A as well. At the end of the evening, I'll rejoin you to share a few thoughts, and then we'll close the program around 7:50. We have the space until 8:30, and I know our speakers are willing to answer a few more questions after the formal portion. So let's get talking. Dr. Brennan. Dr. Brennan is the department head, obstetrics and gynecology at the Cummings School of Medicine, and the Calgary Zone clinical department head, obstetrics and gynecology with Alberta Health Services. She is the first woman to hold this role. Dr. Brennan is an associate professor at the Cummings School of Medicine and is the founder and director of Sex, Gender, and Women's Health Institute. The Sex, Gender, and Women's Health Research Unit, my apologies, within the O'Brien Institute of Public Health. She also co-leads the National GROW training program that aims to develop the next generation of trainees to lead innovation in improving women's biopsychosocial health to close sex and gender-based gaps in Canadian health and society. Dr. Brennan's research focuses on critically examining current treatments in reproductive health, and she's become internationally recognized for her documentation of the risks of pelvic mesh complications and for developing a safer technique for mesh-based urinary incontinence surgery. Dr. Brennan completed her Doctor of Medicine at the University of Alberta, followed by a residency in obstetrics and gynecology, a clinical fellowship in urogynecology, female pelvic medicine, and reconstructive surgery, and a master's in community health sciences at the University of Calgary. Dr. Brennan was program director of the University of Calgary Urogynecology Fellowship and is past inaugural chair of the Research and Development Committee for the Canadian Society for Pelvic Medicine. She is committed to dismantling the stigma and inequities within female reproduction in health to achieve better care and outcomes for Albertans. Thank you for being here to share your wisdom and caring so deeply and so passionately about women and our community.
Thank you, Heather, for the introduction, and to the Calgary Health Foundation for inviting me to speak tonight, and to all of you in attendance. This evening, I want to shine a light on a silent pandemic that is affecting half of the population, and that's the unmet needs in women's health. Just looking for the clicker. Thank you.
Such an important part of the night.
All right. So let's start with the facts. Women make up just over 50% of the population. Yet women's health issues receive significantly less funding and attention compared to men's health. Reproductive health conditions, mental health, autoimmune disorders, and chronic conditions such as heart disease and osteoporosis disproportionately impact women. But women's symptoms are often dismissed or misdiagnosed. Programs to screen for and prevent these diseases are rare, and we haven't made strides with respect to improving treatments. The cornerstone of women's health is driven by our reproductive biology, our two X chromosomes, the ovaries, and the uterus. Examples of this include the fact that female reproductive tract cancers occur at the same frequency that men experience prostate and testicular cancer. However, reproductive cancers are typically more aggressive in women, and due to the internal nature of our organs, these cancers are harder to screen for, meaning they are found at later stages. As a result, when female reproductive cancers are found, they generally have lower survival rates. Despite this, the number of awareness campaigns, screening initiatives, and philanthropy events to support women's reproductive cancer lags greatly behind those designed for men. Or take the staggering statistic that 1 in 5 women experience endometriosis, a condition where the uterine lining grows outside the uterus and into other pelvic organs such as the bowel, bladder, pelvic nerves, and can even extend to the lungs and the brain. Yet despite affecting 20% of us, we still have no diagnostic test or definitive treatment. And as a practicing urogynecologist, I literally cannot stand up and talk without talking about urinary or fecal incontinence, pelvic floor pain, pelvic organ prolapse, and sexual dysfunction. Collectively, these conditions affect up to 50% of women in their lifetime. But no one is talking about this because it's incredibly shameful to reveal that you're having issues controlling your bodily functions and genitals. And as a result of all of this silence, female conditions remain poorly understood, with women often struggling for years to get the right diagnosis and treatment. So what drives the disparities in women's health? It's a complex web of biologic, social, and systemic factors. With respect to our biology, women's physiology is simply different than men's. This diagram shows how much hormonal variability we are subjected to, in contrast to the steady state of hormones in men's bodies. Another aspect of our biology is pregnancy and the associated bodily stress. There is no greater stress test than pregnancy. We are sustaining the growth and support of another human being. This puts strain on our heart, our lungs, our bones, our muscles, our gastrointestinal system, everything. But the effects of pregnancy go well beyond just that 9 months. The pelvic floor is a great example. This is the network of muscles and connective tissue that supports the pelvis. We all have one. But during the pushing phase of childbirth, the pelvic floor is under immense strain, and this leads to weakening and often tearing of those critical muscular structures. And a woman might not notice this in the immediate postpartum period. Many do, but not all. But then in the years after childbirth, the vagina, bladder, bowel, and uterus can begin to drop out of their normal position and into or through the vagina, leading to downstream consequences like incontinence, bulging symptoms, and sexual dysfunction. The effects of pregnancy go beyond the mechanics of childbirth and the strain on our organ systems. As a mother of 3, I find this fact strangely beautiful, but many people do not know that fetal cells and DNA cross the placental barrier and persist in a mother's body. This happens even with the early pregnancies that don't develop further. And as a mom, I find knowing this fact about fetal DNA and my children always being with me sort of comforting because they're getting older and becoming independent. But the fact is, this is foreign genetic material. It causes us a risk of triggering autoimmune responses in ways that will increase women's lifetime risk of inflammatory and autoimmune conditions like arthritis, cancer, and thyroid disorders down the line. So while I think everybody knows that pregnancy can be a tough experience on our bodies, what's not well explained to us as women is that this is not just a short-term period of change, but pregnancy results in permanent alterations in our tissue and genetics. And this results in a cost to our health that our male counterparts will never experience. And then in our later years, we again experience another physiologic event that has no male equivalent: menopause. Menopause is due to ovarian aging, and males simply do not experience a comparable aging of their gonads. It's not fair. The years leading up to your final menstrual period, a phase known as perimenopause, is characterized by massive shifts in estrogen and progesterone. I have heard countless times from friends, family, and my patients that this 7 to 10 year window is a time where they feel like the wheels are falling off. And this is because estrogen has a crucial role in our bodies, and without it, you experience symptoms of hot flashes and night sweats, as well as brain fog and insomnia. These symptoms are real, and they are a result of the brain and the cardiovascular system going haywire in response to hormonal fluctuations. These symptoms are a foreshadowing of the cardiovascular disease that women accumulate after menopause. Yet because menopause is deeply cloaked in the shame and stigma of women's aging and the loss of our reproductive potential, adequate preventative treatment of menopause symptoms are out of reach for most Canadian women. The undertreated and unmet needs of women in menopause is what sets us up for chronic diseases in our subsequent decades of life. And menopause should not just be viewed as an individual woman's issue. It has a massive impact on our society. The Menopause Foundation of Canada released a groundbreaking report last year. Estimates are that untreated menopausal symptoms result in nearly $250 million of lost productivity for employers and a staggering $3.3 billion of directly lost income for women. And this is due to missed work days, reduced job performance, and needing to leave the workforce altogether. And every time I hear this fact, I think of one of my patients. She is a highly successful lawyer in this city who felt that her time had nearly come to make partner. She was 45, her children were grown, and she felt like she was ready to make that leap. But then perimenopause started, causing symptoms of hot flashes, brain fog, and emergency room visits for periods so heavy that she needed to be admitted to the hospital multiple times. She is a prime example of how untreated menopause can result in women failing to achieve their true potential. And while there is little that we can do to avoid these aspects of female biology, I feel strongly that women deserve to be informed of how the female body ages differently, and that we need to advocate that society find ways to improve our health in recognition of this biologic disparity and the important roles that women play in society. And so this leads to another discussion about aspects that shape women's health. And those are social factors that create systemic barriers and inequities. It is simply a fact that the moment a woman is born, she is going to face a lifetime of challenges rooted in structural biases. And this is further compounded for women with lower incomes, less education, and marginalized identities. And we know that these women face significantly higher risks and poorer outcomes during pregnancy, including maternal death. When women do access our healthcare system, it is simply not designed for us. Research has shown that women tend to describe our symptoms using different vocabulary, but that medical professionals are trained to expect and thus respond to the patterns of speech used by men. This can lead our healthcare providers to dismiss and minimize our concerns, chalking them up to anxiety and stress, rather than recognizing the potential underlying conditions. And this results in delayed diagnosis and suboptimal treatment. A final example of social factors is the expectation of women to be caregivers in our community, and the expectation of always putting the needs of others before our own. It's been documented that mothers struggle to engage with health services for themselves while their children are young. And then as our children are becoming independent, many of them are getting squeezed again with the expectation of caring for older family members. I see this every day in my clinical practice when I ask women how they manage to live with such profound symptoms for so long. And the answer is always the same. They just couldn't seem to find the time to put themselves first. And a final factor in the disparity in women's health that I need to tell you about as a researcher is the lack of innovation and discovery due to the fact that women's health research is chronically underfunded compared to conditions that predominantly affect men. So once again, despite making up over half of the population, I have to bring up that we receive a shockingly small fraction of research dollars. If you look at the National Institute of Health Research, which is the world's largest public funder of biomedical research, it has been documented that men's health issues receive a disproportionate share of their resources at the expense of conditions that affect women. 7% of the NIH's rheumatoid arthritis budget went to studies focused on women, despite 78% of rheumatoid arthritis patients being female. When you look at the themes that have the lowest chance of being funded by the NIH, it is those characterized by the words reproductive and ovary. A review of Canada's funding agency, the CIHR, shows that we're no better. Only 2% of funded grants in the last 5 years had the key word of women or girl, and that represented actually only 1.7% of the funding envelope. This systemic gender bias in research funding has consequences. It means there is a serious lack of progress with respect to the tests being developed to diagnose women's conditions, and that new interventions for women's diseases are lagging in development. Closing the funding gap in health research is not just a matter of gender fairness, but it's an urgent imperative to improve the health outcomes for women. So let's talk about the state of women's health in Calgary. Our city has the second highest birth rate in Canada. Toronto's number 1. And despite being the largest city in the province, serving not only our surrounding communities, but also Central Zone and Southern Alberta, we do not have a women's health center of excellence. This is where I'm going to get myself in trouble with the table in the back, where my boss is sitting. But the pictures you see here are of the Women's Health Center, also known as the North Tower of the Foothills Hospital. It was originally built as a residence for nursing students in 1966. It is now the flagship home of specialty women's health in Calgary. I have walked into work every day for almost 15 years, looking at a broken sign that signaled to me the value that the system places on women and the women that I provide care to. The physical conditions of this building are unacceptable. I appreciate that it's old, but this is not okay. The pictures you see demonstrate the sewage that backs up in the clinic routinely, the mousetraps that we need to set for the little critters that live there. These pictures illustrate a point. This is not a nice place to be a patient. Women deserve better. We need to figure out how we're going to get women back on the list of priorities here in Calgary. Meanwhile, in other cities like Edmonton, Vancouver, Winnipeg, Toronto, Halifax, there are dedicated women's health centers and hospitals. And so even if you hold the perspective that this building is better than nothing, which is something that I have been told for most of my professional career, you should also know that despite this building being called the Women's Health Center, we actually contend for physical space with programs that are not focused on women at all. We no longer occupy the largest footprint in this building. We are so tight on space that we don't actually have the capacity to deliver all the care we'd like to. For example, the pelvic floor clinic where I work, we have an over 28-month wait list to be seen. And given how common pelvic floor conditions are, this means statistically, many of you in the room tonight have been a patient there or are waiting to be seen. And so you're familiar with how slow that wait list moves. Perhaps it'll make you a little angry to know, it makes me angry, that we'd love to recruit more urogynecologists to tackle that wait list. But there are literally no additional rooms that they could see patients. And as a result, as department head, I'm not able to recruit them, even though I know that's what the community needs. And not only do we need to expand existing programs, but we need to create innovative new programs to address key priorities that have been identified by women in our community, such as dedicated clinics for endometriosis and polycystic ovarian syndrome, and rapid access clinics for conditions such as uterine bleeding. A rapid access model would recognize how hard it is for women to find time for themselves and how multiple visits to a family physician followed by consultation and specialist follow-up results in absences from work and family life. A rapid access model would provide diagnosis and treatment on a single encounter, providing care more efficiently and at lower cost. But most importantly, it would allow us to detect conditions such as pre-cancer and cancer of the reproductive tract earlier, resulting in better care. But to create these programs requires physical space and funding that does not presently exist for us. And despite the lack of resources, Calgary has managed to attract the talent of almost 100 dedicated OBGYNs, and we provide reproductive health care from girlhood to end of life. Given that nearly every woman will need to see an OBGYN in her lifetime, often more than once, the demand for our services is high, and we work incredibly hard. Yet I know the experiences of the women in this city are that they are waiting months to years to be seen. I'm often asked, why don't I just hire a bunch more OBGYNs if there's so much work to be done? But the reality is that despite the population of Alberta steadily growing, with a projected 1.3 million women being added in the next 3 decades, we simply do not have enough hospital resources to hire new women's health specialists. Hospital facilities have been expanded in the last decade, but the number of new operating rooms for women's health has sorely lagged behind the spaces for other services such as hip and knees and cataracts. As such, I'm just not able to hire OBGYNs. I don't have the required resources for them to do their jobs. And as such, wait lists for procedures and consultations are steadily lengthening. An increase in wait lists isn't just an inconvenience of your time. I cannot stress enough that this not only costs people the quality of their life, but the length of it. Every single one of my last 5 gynecology shifts at the Foothills Hospital involved telling people that their long-standing vaginal bleeding was due to advanced uterine or cervical cancer. And every single one of these women told me a story of how the system has failed them here in Calgary, including symptoms being ignored, misdiagnosed, and women never getting off the wait list to be seen before things became dire. And if the lack of hospital resources wasn't enough, Calgary also lacks a dedicated research institute or center for women's health research. These do exist at other top universities in Canada. Research has shown that academic infrastructure greatly improves innovation, including the quality of discovery, adoption of findings, and the amount of external funding that scientists bring for work. A research institute is a major pull for highly qualified people, and without one, we struggle to bring women's health scientists here, which then results in less research and development happening in our city. Despite this, Calgary has a core group of women's health researchers who punch above their weight. Our group has demonstrated the value of investing in enhanced recovery programs for women who've undergone reproductive cancer surgery. We've discovered that women may be able to improve their experience of menopause symptoms through extending breastfeeding, and we have explored the impact of pregnancy on cancer survival. The impressive productivity of women's health research in Calgary also includes the fact that the Cummings School of Medicine is home to our national research training program, GROW. GROW was born of the shared experience of struggling to find funding, mentorship, and collaboration in early research careers. And we envisioned a future where those of us who have navigated the rocky landscape of women's health research in Canada would in turn educate health research trainees from across the country from various disciplines about the salient aspects of women's health and open up our professional networks to the younger generation in order to foster connections and accelerate innovation. GROW has been highly successful and is now in its 3rd intake of students. Another demonstration of Calgary's small but mighty excellence in women's health research is that over the last 2 years, as the federal government has attempted to address gender inequities in funding with a one-time $20 million program called the National Women's Health Research Initiative, that within that competition, researchers from the U of C have been associated with nearly 25% of that funding portfolio. When you consider that there are over 100 universities in Canada, this is an astonishing fact. And while women's health researchers in Calgary are making incredible contributions, we do this in spite of the infrastructure provided to us, not because of it. Can you imagine what we could do with actual support? So let's imagine for a moment a world where women's health needs are put first. I believe we can create a city and a province where every woman can thrive and reach her full potential through supporting women's health as the cornerstone for a prosperous community. This is not a distant utopia. It's a reality we can create, starting with this conversation tonight. And so how do we move forward? We need champions. We need collective action to demand equal resources, funding, and innovation. This includes raising the profile of women's health, and everyone here tonight educating someone else about the unmet needs. And we need to demand that the health system direct resources to close this gap. So tonight, let's commit to being those champions, and let's work together to make sure that every woman is seen, heard, and cared for. Thank you.
Excellent presentation, thank you. I have a question regarding women who don't allow their bodies to go through menopause by labs, compounded drugs, etc. How are the pros and cons? What are these affected? I'm thinking of 2 or 3 specific women who are in their late 60s, early 70s at this point, still having their periods.
So,
thank you.
Yeah, this is a great question. There's a lot of questions about menopause. And in the late 90s, early 2000s, I'm dating myself, I was a medical student at the time, there was a research trial that came out, and overnight, everyone stopped taking hormone replacement therapy. Everybody threw it out. It resulted in decades of mass confusion, misinformation, generations of medical professionals who don't know how to diagnose, treat, or safely address menopause. And of course, what fills that gap is usually nonsense, including compounds and formulations that have not been tested with unknown safety profiles, women receiving information from questionable sources. There's a lot of information that we don't know. What we actually have found is that hormone replacement therapy, the safety of it is greatly related to the timing, the route of administration, the formulation, and for how long it's given. And so every patient or every person's case is unique. But people should not be scared of hormone replacement therapy. I just wish there were enough people in the city who could provide it safely, and that I didn't have to hear about individuals taking creams, compounds, and maybe not being on a healthy form of HRT into their 60s and 70s. So it's a huge gap. Science really set us back many decades ago on that one.
Okay, I have some from the audience. During menopause, in regards to protein intake during mealtime, specifically non-red meat protein like chicken, dairy, eggs, etc., is there a heart protective minimum in grains per kilo that we should eat per day?
I feel like I need a registered dietitian to take that one on. But again, what it's showing is that certain disciplines, and so nutrition is a discipline, where women's health specific information is sorely lacking. It is being recognized that things like the Canada Food Guide do not recognize the protein requirements needed to support women through perimenopause with our hormone shifts. All of us have probably noticed it's harder to maintain the body shape and physique that we used to have, but we don't have the science to tell us what we should be eating. So again, it's a huge gap.
Did you want to go with your question?
Okay, thank you. I was just wondering, I've talked to other women, and some seem to be taking hormone replacement later in life. So what's a safe age spread, and how long should you take them?
Yeah, this is again an excellent question. I have numerous patients that will say to me at 70 or 75, I'm ready for hormone replacement therapy. Because the sad thing is nobody tells us that 1 in 10 women will have hot flashes and night sweats until the day that we die. And they're so happy, they're so excited, they're like, I put it off and I'm finally ready, and I have to tell them, oh, I think you missed the boat. Because what we do know is timing is everything. So people that are going through menopause now and are thinking maybe they want to take HRT, now is the time. Now is the time to start. So close to the menopausal transition. 10 years after, that's when the risk comes. That's what we've learned. Is that's when hormones, bringing them back, has negative effects on the heart and cardiac calcification. In terms of duration, 5-10 years seems fine. And for some of us, we'll be on it forever. I like to joke with my department members that I will be on HRT till my last breath. But these are decisions that women can make. They just need to be informed of the pros and the cons. And they're not all cons. There are pros to hormone replacement therapy long term. Yeah.
Very recently, I've read a report that's come out about some new research on ovarian cancer, and I'm just wondering, has that reached Calgary? I'm sorry, I'm vague on where I even read it, but it may be coming out of Japan, but I'm not sure. But are you familiar with that?
I think you might be talking about prophylactic salpingectomy, which is the most exciting thing in ovarian cancer, because prior to this, we had nothing. We have no screening test, nothing that works. But what researchers at the University of British Columbia have found is that if you take out a woman's fallopian tubes, when she's confident that she's no longer going to be childbearing, you reduce her risk of ovarian cancer by 90%. And this has been proven with some very robust data from the province of BC. This is the first time we have had anything like that. I mean, this is the biggest thing in ovarian cancer research. And so I can certainly say that the Calgary zone has been an early adopter, and we offer prophylactic salpingectomy to any woman if we're operating in her pelvis, because we are very motivated to tackle this horrific disease.
Yes, my question actually is along the lines of the conversation of ovarian cancer. Baseline hormone testing. I'm curious at your thoughts on that, and my understanding is it's not a practice standard, and I'm curious as to why it's not. What would be reasons that it's not? I see so many positive and effective screening programs in our health system, and I'd love to know what your thoughts are on that.
Yeah, the main reason that it is not tied to outcomes is that our hormones fluctuate so much in the course of a single day that a single lab test or even a series of lab tests aren't really meaningful. What's important is to treat the symptoms. So menopause is universal. We can pretty much predict when perimenopause is starting too. So anyone who's above 45 is in perimenopause. What's better than a lab test is actually those symptoms of vasomotor, hot flashes, and night sweats. And that's when we should be treating, and that's when we should be talking to patients. The lab tests aren't useful. The salivary lab tests that pharmacies are offering are totally unvalidated. But we should treat the person who's in front of us and the symptoms that they tell us about.
Excuse me, when you talk about HRT, is Vagifem HRT or is it?
I love Vagifem.
All
so
right.
It's not HRT, but I'm so glad somebody has asked about Vagifem. So Vagifem, Premarin cream, vaginal rings, these are all formulations of estrogen that are used inside the vagina because almost every woman is going to experience a condition called genital urinary syndrome of menopause, where the vagina feels dry, irritated. Women may feel like they need to go to the washroom more often, they can't hold it. It can get so bad that people are bleeding just from walking. The only treatment for this is a tiny amount of estrogen that does not move the hormone levels in your blood. So lots of good studies that show your blood levels don't go up. But it is the gold standard. It works for 90% or more of women with no risk of breast cancer, no risk of uterine cancer, but a treatment effect and a massive preventive effect. I don't get paid by the makers of Vagifem or Premarin, but you stay on it forever. And hormone replacement therapy, you still need Vagifem. Everybody needs Vagifem who's a woman.
I know. Okay.
I'm very interested in hearing the sad state of affairs in terms of the facilities dedicated to research into these areas. So where has the initiative come in these other cities that clearly have some state-of-the-art research facilities? And, you know, where has Calgary missed the boat, and what's our first step forward with this?
So I'll talk about Edmonton. I was born in Edmonton. Please don't boo me. But the impetus for the clinical push in Edmonton, I was a medical student and I got to participate in Lois Hole's care at the time. But Lois Hole passing away from ovarian cancer was the big push in Edmonton to get the ball rolling for a women's health hospital. And the Research and Innovation Center that exists in Edmonton, again, is born from the experience of a well-known businesswoman who had a horrific experience with menopause. And she leveraged her connections and her stature to bring something better for the women in her community. And so I'm sure my boss is wondering why I put that awful slide of the North Tower up there, but it's because women don't get things just from asking nicely. We need champions and we need to get angry, and I think that is the way forward for Calgary Zone as well.
I'm going to read an online question, and then we have a few more over here. I've been told that because I am menopausal at 62, that I don't produce estrogen anymore, and that I don't need any. Is that true? I've also been told that my joints, knees, and hips would not hurt so much if I had some estrogen in my system.
So at 62, you have about 90% less estrogen than you did before menopause. We always have a bit of it around, and men too. And that is from hormones created in our adrenal glands, which sit on top of our kidneys, that then get converted to very weak estrogen in the adipose or fat cell under our skin. So we're never down to zero, but it's a big loss. And the type of estrogen that's left is weak. There is compelling evidence that use of HRT may slow some of the wear and tear on joints. And so while I'm not saying that HRT is going to solve any particular person's musculoskeletal pain or arthritis issues, it is a consideration for people when they're deciding whether or not they want to go on HRT. And of course, specific to this person, they need to figure out the timing of their menopause and hopefully access someone who can tell them whether this would be considered a safe time for them to look at using it.
We have time for one more question, and I think we had one on deck over here. Please do write your questions down on the index cards. Write it down. Because we would like to get answers for you, but we need Dr. Sandra to come up and do her presentation as well. So one more question. Please do write those questions down. They're very important.
Okay.
I'm really, really glad that you said something about the women's clinic, because I won't go there anymore. Like, I've had terrible experiences there. And so what would be your vision for a women's clinic in Calgary, and what would you need from the community, from AHS? Like, what is the overall vision to have a research, education, and care center for women?
So I'd love to see all 3 pillars housed in the same space. They span 2 different organizations, but the goal that we're really needing is a term that the federal government calls the learning health system, which is where we continually and iteratively learn from our past experiences and do better. And we can't do that without data and analytics. So it makes sense in an ideal world that they're housed together. We need a better facility. We need one that is gender sensitive, one that is accessible, one that is trauma informed. We need the priorities of women in our community to be represented. So we don't just need an OBGYN clinic in a nicer building. We need new programs. And I hear every time I'm in the community about endometriosis and people struggling to get the high quality surgery that some of my recruits are able to provide, but they just can't find their way there. Probably the second thing I hear most is polycystic ovarian syndrome. When polycystic ovarian syndrome is not treated, women experience infertility, reproductive tract cancers, and cardiac disease. We don't have a clinic. We have some incredible PCOS clinicians in this city, but we haven't given them a space for family physicians to refer to. And we also need safe, high-quality minor procedure suites, and that's really what's needed for a rapid access clinic. If somebody has uterine bleeding after menopause, it should not take the average of 6 healthcare encounters that it takes before you end up in a major OR. You should be able to be triaged and seen on the same day, have a minor procedure called a hysteroscopy. Let's make sure you don't have cancer. Let's remove any polyps that may have been growing, and let's get you back to normal. So we need different types of infrastructure. We need some minor procedure suites.
Thank you so much, Dr. Brennan. There's so much knowledge in that brain. I just want to soak it all in. So many questions, and I know there's lots more questions out there. So thank you for your patience. Thank you for your presentation. That was very eye-opening. Next, I'd like to bring up Dr. Rupinder Sandhu. Dr. Sandhu is leading women's cardiac health in Calgary. Born and raised in Calgary, Dr. Sandhu brings a wealth of experience to Calgary as the new director of the Libin Cardiovascular Institute's Women's Cardiovascular Health Initiative, director of the Women's Cardiovascular Clinic, and the Martha Brower Chair in Women's Cardiovascular Health Research. Wow. Dr. Sandhu's experience and education are varied. She received her undergraduate degree in biological sciences from the University of Calgary and her medical degree from Ross University School of Medicine. Her internal medicine, cardiology, and cardiac electrophysiology fellowships were completed at Case Western Reserve University in Cleveland, Ohio. From there, Dr. Sandhu obtained a master's in public health from the Harvard School of Public Health and a research fellowship at Brigham and Women's Hospital. Prior to her return to Calgary, Dr. Sandhu worked at Schmidt Heart Institute in the Department of Cardiology at Cedars-Sinai Medical Center, where she was an electrophysiologist and associate professor. She has more than 130 research publications in peer-reviewed journals, book chapters, and editorials, focusing particularly on atrial fibrillation, syncope, I probably am not pronouncing that correctly, and sudden cardiac death. Dr. Sandhu has held numerous prestigious positions, including co-chair of the Canadian Cardiovascular Society. Her main research focus is to gain a better understanding of atrial fibrillation epidemiology, identify gaps in treatment, and pursue strategies to improve outcomes. Dr. Sandhu has received grant support for research from federal funding agencies in Canada and the US. She's been on writing panel or co-chaired several cardiovascular guideline documents and currently serves as a member on the national and international societies. Dr. Sandhu's been on the writing panel and received grant support from the Heart and Stroke Foundation of Canada, Canadian Stroke Prevention Intervention Network, and National Institutes of Health Research. She currently serves as a member of the Heart Rhythm Society Research Committee, the Heart Rhythm Society AF Quality Improvement Committee, Centers of Excellence Working Group, and Canadian Heart Rhythm Research Committee. Wow. I don't know how you keep track of all of that. She is, and I also wonder what I do with my spare time. She is directing the future of heart rhythm and disorders research and clinical care in Calgary. Dr. Sandhu.
Great. Okay. Well, thank you so much for that kind introduction, and I'd like to thank the Calgary Health Foundation for having me, and all of you in person and virtual audience for taking the time to listen. And if you thought that I was going to follow up the wonderful presentation Erin gave with a feel-good story, you're going to be disappointed. Heart disease is the leading cause of death in women, more than all cancers combined. In Canada, cardiovascular disease claims one woman's life every 16 minutes. So think about that. For the time that we're sitting here attending this event, at least one whole table of participants would have died of cardiovascular disease. Underrepresentation of women in heart research has resulted in delays in discovery and effective translation into clinical practice. And consequently, heart disease in women remains underrecognized, underdiagnosed, and undertreated. And importantly, nearly 40% of people in Canada are unaware of this critical information. So I want to show you a little bit about the data that's out there, because we know that clinical practice is really based on the evidence we get from research. And women have a disproportionate representation. So this is nicely demonstrated by the figure, which shows the percent of women in randomized clinical trials, so that's our gold standard way of doing research, in the gray bars, compared with the percent of women in the population with a given disease. So for example, if they have coronary disease or they have heart failure, and that's shown in white, and then the percent of women who die because of those diseases. And you can see that many of the trials excluded women, and you can see from the figure that the amount of death that occurs is not represented by the proportion of research that's being done in these women. So we heard a little bit about the lack of research, and we know that women's health research is underfunded. So if you just think about the stats here, only 8% of funding dollars are from CHR, so the big federal funding agency in Canada, and 1.2% of Canada's research chairs, the people that lead research programs in women's health, are women. And what do we know about what the public and providers know about women's heart disease? So this was a recent survey from the US, and it found that women in 2019 were 74% less likely to identify heart disease as the leading cause of death compared to women in 2009. So less women know that cardiovascular disease is their leading cause of death. And that is such a sad trajectory that we're on. And then when you talk to providers, only 22% of primary care physicians and 42% of cardiologists felt extremely well prepared to assess those women that came to them for their risk of heart disease. So not only does the public not know about the risk of heart disease, but the providers don't feel comfortable when women do come to seek help. So let's take an example every day of someone who may have some chest discomfort. What do we know? That half of women who experience a heart attack have their symptoms go unrecognized. Why is that? Well, when you think about heart attacks, for men, typically they present with this central chest pressure. They feel a tightness, they may feel nauseous, they may get a sweaty sensation. And that may be true for some women, but for many women, they present with symptoms that are not consistent with what we know as typical heart disease. So what do they present with? They present with discomfort in their neck and their jaw, in their shoulders. They feel nauseous, fatigued. They may feel short of breath, but they may have other symptoms like trouble sleeping. They may feel just overall fatigued. Can you imagine going into your provider and saying that you feel just fatigued? They're going to say, you're working way too hard. Don't worry about it. But that's a common symptom of heart disease. And why is that? It's because not all heart attacks are due to blockages in the heart vessels. So that's what we typically think about. There's a blockage in your heart vessel that causes a heart attack. But for women, much of the time, it is disease in the small vessels of their heart. And those small vessels are not seen by the typical tests, like an angiogram you do to look for blockages. And a lot of times, especially younger women, so less than 50 years of age, they can suffer a sudden tear in their heart blood vessel, which can cause a heart attack and put them at risk for dying suddenly. And their risk factors are completely different. Depends the number of pregnancies they have. It can depend on stress or intense exercise. But if you don't ask those risk factors, then you might not be suspicious that that's the cause. So what are those risk factors? Well, there are certain risk factors that are the same for men and women. Smoking, high blood pressure, diabetes. But what we have to know that is even amongst those traditional risk factors, women have a greater severity or impact of those risk factors when it comes to their risk for heart disease. And then we know that there's a host of other specific risk factors that are just unique to women that put them at risk for having heart disease. So you'd think, well, you're probably convinced by now, why focus on women's heart disease, or why focus on women's health in general? But let me give you a little bit of data here. So this is data from Alberta. And I apologize because I am trying to work the computer at the same time. So just give me 1 second. Okay. Women with heart disease, we know, face systemic inequities as they navigate the healthcare system. So compared to men in Alberta, women are more likely to present with symptoms just prior to having a major event. They're more likely to have delay in treatment. They're more likely to wait in the hospital longer. And when they're in the hospital, they don't get the testing, so whether it's angiograms or ultrasounds of their hearts, and they're less likely to be put on the medication that they're supposed to, that we know is evidence-based. And like Dr. Brennan had already said, there's many predictors of disparities among Canadian women that put them at risk for heart disease. So whether it's that they belong to marginalized communities, or just based on their ethnic and racial background, their socioeconomic status, we know that these factors play an important role in your risk for heart disease. So what I think we need to do right now is to stop the discussion and just take action. It's time to transform the heart health and health system for women by addressing critical knowledge and care delivery gaps through a comprehensive approach to cardiovascular care across the life cycle. So how are we going to do that? Well, the Libin Cardiovascular Institute and support from the Alberta Health Services, they've really been at the forefront of recognizing women's heart health as a priority. And they created this Women's Cardiovascular Initiative back in 2019. And during this short period of time, they've achieved several successes, including trainee scholarships and fellowships. They hosted a wonderful international trainee symposium in Banff. They secured funding for the research chair that I hold. Libin members are leading research and training across the woman's life cycle. And last year, as a priority-setting exercise for research within the Women's Cardiovascular Initiative, they completed this wonderful assessment, and their number one area for research was sex-specific causes for cardiovascular disease. And that resulted in fundraising efforts for Catalyst grants to help young trainees start their research. And then it's finally ended last year with the hiring of the new director, and here I am. So I think it's really important to acknowledge the expertise that we have at the Libin and the Cummings School of Medicine and within the Women's Cardiovascular Health Initiative. We have 57 members and 72 trainees, which is tremendous. So we can talk about all the problems that there are, but we also need to think about a solution. So I want to present for you what I would like to do with the Women's Cardiovascular Health Initiative. And it starts with our vision. So our vision is to be a globally recognized center of excellence in women's cardiovascular health, care delivery, research, education, and knowledge translation. And the mission is simple. It's to save women's lives through prevention and treatment of cardiovascular disease. And there are core values we need to think about as we are trying to implement our vision and our mission. And that means that we are providing excellence. We're promoting teamwork and collaboration. We're ensuring patient-centered care. We're pursuing innovation. We're encompassing integrity and embracing diversity and inclusivity. And all of this keeping in mind our marginalized communities. So the Women's Cardiovascular Health Initiative will focus on 4 pillars: clinical care, research, education, and community outreach. And I'd just like to spend a few minutes going through each of them in a little bit more detail. So the first is clinical care. You can see it's a schematic. So I don't even have a picture of a debilitated building or clinic space because we have no space. Okay. I would love to have a space. I would love to have a dedicated space where we can provide specialized care to women who are at risk and those women with heart disease. And I want that care to be multidisciplinary and team-based. So what does that mean? It means we think about the entire woman. We think about their mental health, so we have a clinical psychologist. We have a social worker. We have a dietitian. We work together with our partners in terms of what other conditions are there that affect heart disease. So like working with Erin's team. That women's cardiovascular health clinic provides a unique, long-term, sustainable solution to address the ongoing deficiencies in heart health of women. And it provides the best opportunity to deliver high-quality research and individualized, accessible care. So I would love to take this picture of a Women's Cardiovascular Health Center of Excellence and make it a reality. There's a strong need for the education of the differences in the way sex and gender presents for cardiovascular disease. And that starts with our learners. So if you think about going to a provider now who doesn't feel confident assessing a woman with heart disease or women that are at risk for heart disease, where does that begin? That begins in terms of their education. So it has to start early. It's getting that message into high schools, into medical schools, into our residency training program. Throughout all my many years of training, I never had one rotation that was focused on women's cardiovascular health. And what do we want to do about it? Well, we need to support our young trainees, and we need to do that through a host of different avenues. So whether it's scholarships, it's research grants that are long-term and sustainable, it's important that we're building capacity, because if we're investing now in our trainees, they become your providers when you need them later on. Oh, I realize you're not, okay. Community outreach. I think this is the most important pillar that we have. And it's because we need that partnership between both the institutions, government, and you. And I would love to have a formal program where we have that community engagement on a routine basis. So whether that is, oh, I think this is advancing. So whether that is having an ambassador program, doing public lecture series, having women's heart health checks in the community, I think all of that needs to be done so that more women know about their risk for heart disease. So it wouldn't be a presentation if I didn't have a chance to talk about my research. So I want to talk a little bit about atrial fibrillation. Does anybody in this room have atrial fibrillation? Oh, okay. Oh, okay. Few hands are going up. So for those of you that don't know, atrial fibrillation is the most common heart rhythm disorder that we deal with in clinical practice. It's an abnormal, irregular rhythm that occurs in the top chamber on the left side of the heart, and it can be fast and chaotic, and we see it as a chronic disease. And what we know is that atrial fibrillation is just increasing in time, and that's because those risk factors for atrial fibrillation, whether it's obesity or diabetes or high blood pressure, are also increasing. And age is the biggest risk factor for atrial fibrillation. Well, we haven't figured out yet a way to stop aging. And why is atrial fibrillation so important? Well, it's the leading cause of stroke. It can cause a weakening in your heart muscle. It can lead to cancer, and it can increase your risk for death. What are the differences between men and women in terms of your risk for atrial fibrillation? Well, for a long time, we've had studies like this, which have shown that the women's risk for atrial fibrillation is half of that compared to men. But if you can see from the figures, this data is 15 years old. And so people think, well, risk of AFib is less for women. We don't have to take their symptoms seriously. So this is research from my mentor, who looked at a very contemporary cohort of patients. And so this was within a trial that looked at vitamin D and omega-3. And they tracked women and men for atrial fibrillation. And what they found was if you adjusted for height and body size, actually women have a higher risk for having atrial fibrillation than men. It's just that nobody bothered to do those adjustments of risk before. Risks of atrial fibrillation, those factors are the same as cardiovascular disease. It's high blood pressure, it's diabetes, it's obesity. There's a host of risk factors that we know. And you can see in this slide, it still says male sex. What we're being taught hasn't caught up to the most recent data. And how much do those risk factors cause atrial fibrillation? Well, what we've realized is if you think about all the traditional risk factors for atrial fibrillation, they only account for about half of your risk. So what does that mean? That means the other half of your risk nobody knows about. So that left me to think about the reproductive lifespan factors and whether that might be the reason why women are getting atrial fibrillation more than men. And when women do get atrial fibrillation, they're at higher risk for stroke and for heart failure, and they die more often. So this is just a busy schematic that you'll see when you write grants, you have to explain to reviewers why you think something is important. And the more complicated the figure is, I think the more they think that you've thought about it a lot. So I took a lot of time to think about all the ways that atrial fibrillation could occur. I put this figure together and I tied it all to reproductive life course events. So things that happened in your early reproductive life, things that happen in pregnancy, and things that happen in late menopause. And the reason that we thought about this is from research that I did very early on when I was in Boston. And we looked at what your risk for atrial fibrillation was depending on how many pregnancies you had. And the more pregnancies you had, the higher risk of atrial fibrillation there was. And then we thought, well, why is that? Are all pregnancies equal? Could there be adverse pregnancy outcomes that are the reason why you have an increased risk for atrial fibrillation? So this is just a study that looks at the differences between the different risk factors during your reproductive lifespan, and they all show that there's an increased risk for atrial fibrillation. Premature menopause. So if you get menopause less than 40 years of age, you can have an increased risk for atrial fibrillation. Your age of menopause, so having an earlier age onset of menopause versus later, can increase your risk for atrial fibrillation. And hormone therapy, as we've talked about before. Well, hormone therapy is not all equal. So if you're given an estrogen-only based hormone therapy, you're at risk for atrial fibrillation. Those are only a few studies, and those are really only the data that exist. And there are major limitations in that data. And so I thought, well, this would be a great area of research. I was able to take advantage of my long collaboration with Harvard and the Nurses' Health Study to propose to do a study with the Nurses' Health 2 cohort So if you're not familiar with the Nurses' Health 2, or Nurses' Health in general, it's a wonderful cohort of predominantly women. They've been followed for 50 years. They've answered very detailed questionnaires, including around the times of their pregnancy. That is such a rich resource to be able to do research. So I propose to look at early reproductive factors, pregnancy-related factors, and late reproductive factors with your risk of atrial fibrillation. And then wanted to look to see, okay, there are certain scores that you can assess a woman's risk. What if you added one of those significant reproductive lifespan factors to it? Could you better predict who is going to get atrial fibrillation and who's not? So I submitted it to the National Institute of Health. It actually scored really good. I'm not sure if it's going to get funding because it is at the whims of the US government and Congress, and we all know what's happening there. So I'm really hoping that I don't have to rely on US politics to be able to do this really important research. So I would just leave with this. The one thing, one fact that you can take away from tonight's talk is that cardiovascular disease is the leading cause of premature death in women. That there's underrepresentation of women in research, and that is leading to critical delays in our treatment. If we want to improve outcomes for women, we need to focus on having specialized care that is delivered to them. We need to improve our education. We need to invest in our research, and we need that strong partnership with community. And the Women's Cardiovascular Initiative is here to make that happen, and we need to do that in partnership with the government organizations and the community and any potential funding partners that we have. Thank you. So I apologize for trying to do the laptop at the same time. You can see that multitasking is not my forte. Dr. Sandy, thank you so much. Again, just eye-opening information. I guess I'm at risk. I have to watch myself. So now, again, we want to open the floor to questions. So I have the first one. Would you explain what stage the Women's Heart Health Clinic is at now, and what are the barriers that you're facing? Yeah, that's a great question. We are still in the planning stages. We actually have a great plan to be able to implement the clinic, but we don't have any dedicated spacing. We don't have resources for just the basic elements that we need to run a clinic. We have incredible clinicians with tremendous expertise that we would love to get together and start to help the women that are in our community, but we just can't do it.
So you were mentioning the symptoms of women presenting for heart attack or potential heart attack, being pain in the sort of neck and shoulder in this area, as well as a lot of fatigue. So you've just described an awful lot of chronic pain, conditions that I believe are also predominantly women. If you're feeling that stuff all the time, is there a change in those feelings if it is then a potential cardiac event? Like, I would be at my doctor every week saying, check my heart.
Well, it wouldn't be a bad thing for you to do that because maybe they haven't thought about your heart as the reason why you have those symptoms. I think, it really needs to be a detailed conversation about what your risk factors are, the symptoms, what testing has been done that may help to, for example, make cardiac disease less likely of a diagnosis for you. But I would encourage women who have these symptoms to tell their provider, because that is one of the issues, that for them, they also dismiss it as not being related to their heart.
So I guess my question was more, if you are dealing with that and you've got care for that and you have seen a lung and heart specialist for certain things, would there be a difference in a change in that usual feeling that you have that is explainable? So you do know you've got something. Would there be a difference in that feeling if it is now a cardiac event?
Absolutely, you may have a change in your symptoms, and maybe it's that you have a diagnosis and you're being treated for it, and then you develop maybe it's a greater severity. Maybe it's lasting a little bit longer than usual. So I think any change in your symptoms that are similar to what I described should definitely be brought to your physician.
I have a couple of online questions. You basically described how I feel all the time: neck pain, jaw pain, fatigue. What kind of tests can I ask for? I'm used to being dismissed by doctors as being anxious.
Well, I want to apologize on behalf of healthcare providers for